Brian, I want to start with you. How's Medicare doing?
Well, from a fiscal position, Medicare is the number one challenge that the federal government faces. Its cost growth is on an unsustainable trajectory. And, it's increasingly adding to the national debt. So there are dedicated funding sources for Medicare. People pay payroll taxes for Part A, which is the hospital insurance component of Medicare. They pay premiums for Parts B, which are for physician services, and for Part D, which is the prescription drug component. But those pieces, the premiums and payroll taxes, are declining as a percentage of total expenditures. So Medicare is increasingly reliant on general revenue. And of course, given the large deficits that the country is facing, Medicare's growth is adding to our deficit challenges.
If you don't mind drilling down on that, the disconnect between the dedicated funding sources and the size of the program, uh, what are we looking at in the years ahead?
Part A, the hospital insurance component, is funded by a payroll tax. The payroll tax historically has covered expenditures, but in the past few years, expenditures exceed revenues. So we are decreasing what's called the trust fund. The trust fund is really a fiction. There is no money in the trust fund. But when that sort of fictional account reaches insolvency, there'll be large benefit cuts. That is projected to happen within the next 5 to 10 years. Medicare, in part because of the aging of the baby boomers, in part because of the growth of healthcare spending generally, it's over $1 trillion program now. It's projected to roughly double over the next decade. And of the growth, most of it is not going to be funded by those dedicated revenues, the premium payments for seniors on the program, or the payroll taxes that they've paid that come into the program. It's reliant on general revenue transfers. The biggest growth in Medicare is the physician services, the Part B side. And the vast majority of that is a transfer from general revenue into the program.
Michael, when we talk about what beneficiaries pull from the Medicare program and the taxes that are paid to support the program, that disconnect that Brian just talked about should seem obvious to just about anybody.
Where the money comes from, whether it comes from dedicated payroll taxes for the Medicare program or whether it comes from general revenues, I think is much less interesting than the overall amount that Congress is extracting from taxpayers in order to pay for the Medicare program. Medicare covers or subsidizes medical consumption directly or indirectly for more than 60 million people. It spends an average of about $12,000 per enrollee. Some get a lot more than that out of the Medicare program. The subsidies they receive vastly exceed $12,000, but the vast majority receive subsidies are less than $12,000. On average, comes out to be about that much. And as Brian said, the real danger is, well, that's a pretty big number, first of all, especially, if you compare the Medicare program to other countries, even the Medicare program spends more on seniors than other countries' health systems spend on their elderly. But it's also growing rapidly. Medicare is growing as a share of the economy. It is the principal reason, and Medicare and other federal health spending is growing as a share of GDP, and they are the reason why the federal government is growing as a share of GDP. They're the reason why the national debt is growing, and interest payments on the national debt are growing as a share of GDP. And the really interesting thing about Medicare's growth is if you compare per enrollee spending in the Medicare program to the same figure for Social Security, what you'll notice is that per enrollee spending in Social Security does not grow as rapidly as it does in Medicare. And a lot of people think that that's because healthcare is special and there are new technologies that result in higher Medicare spending. I think the cause is much simpler. The reason why per enrollee Medicare spending grows about a percentage point faster than GDP, whereas per enrollee Social Security spending grows at about the rate of GDP, is that on the Medicare side, you have tons and tons of lobbyists who will go to Congress, who will go to the Medicare bureaucracy and say, cover our stuff, increase the prices the government pays for our stuff. And this lobbying is so ubiquitous, it's so intense, it's so high pressure that lobbying by the health sector of the economy has outpaced lobbying by every other sector of the economy by far for 20 years running now. Most people think, defense contractors must spend the most on lobbying. No, it's not. It's the health sector of the economy. It spends more than 4 times what the defense industry spends on lobbying. And that is why Medicare spending is growing so rapidly. It's not because there's anything special about healthcare. If Congress wanted to, it could shut off growth in Medicare spending tomorrow, but it doesn't want to, because when Congress purchases something like healthcare, the people who provide that thing have a huge incentive to lobby for more spending. And contrast that to Social Security, where the government just gives seniors cash. And when the government gives seniors cash, you don't get the kind of lobbying by the people who the seniors spend that money on to increase Social Security spending, because they don't know if that lobbying expenditure is going to come back to them in the form of more money from seniors or bigger subsidies from government. And I think this points toward how we can finally reduce the growth of Medicare spending, which is to make it look more like Social Security. Instead of having the government define a package of health insurance subsidies or healthcare subsidies that people are going to get, or give people a voucher, to what is essentially a voucher, to choose between traditional Medicare or one of these so-called private Medicare Advantage plans. Just figure out how much the Medicare program would give a private insurer to cover a given enrollee. That means Medicare would set a higher amount for people with expensive medical conditions, and then give the enrollees the cash. Because then you will not only disable the lobbying dynamics or eliminate the incentives for the industry to lobby for more and more Medicare spending all the time, but you'll also make Medicare enrollees much more price sensitive. They will care about the price of their health insurance and the price of the medical goods and services that they are consuming in a way they just don't right now. That will make healthcare more universal by causing prices to plummet. The Medicare program will become less expensive. Seniors will get higher quality medical care. No one will have to go without any medical care. And we can finally try to get the federal budget under control.
Michael brought up Social Security, and I agree with Michael. I think Social Security is a much more efficient program because the government doesn't set all the prices. They don't set rules. They're just cutting checks. I think one of the really important things to level set with the American people on both Social Security and Medicare is that it's a pay-as-you-go transfer program. So people that are working now, they are paying payroll taxes through both programs to finance benefits for seniors who are on the program. It is not set up as people pay during their working lives and they have an account set aside for them when they retire that they draw down on. One of the main points that Paragon is making, and we're going to have a paper come out next week on means testing in the Medicare program. And means testing means that wealthier seniors would pay more for their Medicare benefits, largely in higher premiums. The program is relying on these transfer payments, and seniors on the program tend to get 3 times as much in benefits than they pay in terms of payroll taxes and premiums. When you hear people say, and seniors say, we've paid for these benefits, it's just not true. They're getting far more in value from the benefits when they retire and start collecting from being enrolled in Medicare than they have paid. And that gap actually is set to grow over time. And it is just one of the things that is fiscally unsustainable about the program is we just can't have generation after generation that receives so much more out of the program than they have paid in during their working lives and in premium payments.
As I like to say, I don't get so much as a thank you note from my parents and grandparents when it comes to Medicare.
I have raised this with my parents before too, yes.
The first Medicare enrollee was former President Harry S. Truman, who received subsidies from the Medicare program after having paid absolutely nothing into the program at all, because Congress created the taxes at the same time it created the subsidies. At the signing ceremony, President Lyndon Johnson handed former President Truman his Medicare card, which President Truman could then use without having contributed anything to the program at all. And every successive generation has taken more out of the Medicare program than they have put in. Every successive generation has exhibited that Harry Truman problem.
Michael, you mentioned that the idea that Social Security is a much better run program, at least along one dimension. I don't know if that has a whole lot of purchase that we should make Medicare more like Social Security. I wouldn't put it on a poster. But when it comes to reforms to put people in greater control of the money, at least make the revenues rational with respect to the spending, what are some other ideas to get us there?
Well, if I can say one more thing about using Social Security as a model for Medicare reform, what that would do is it would apply to the Medicare program the traditionally democratic idea of a public option, where the government runs a health plan and it competes with private insurance on a level playing field. Right now, the Medicare program already has a public option. The traditional Medicare program, where the government writes the checks to doctors and hospitals, competes against private health insurance companies in the Medicare Advantage program for seniors, for enrollment. And so the seniors can choose. They're going to get a subsidy. They can either get it through the traditional Medicare program or they can go to one of these private Medicare Advantage programs. And so you already have a public option in the traditional Medicare program that's competing against those private insurers. The problem there is that the playing field is not level. There are all sorts of things that tilt the playing field in favor of traditional Medicare in some cases and in favor of Medicare Advantage in other cases. And if you want to level the playing field between those two, the only way to do that, the only way to apply this traditional democratic idea to the Medicare program is to give the seniors cash. Give them a Medicare check that is bigger for people with high-cost illnesses, bigger for lower-income people so that the healthy and wealthy get smaller checks, and then trust them to spend it like the Social Security program does, because that is the only way to eliminate all of those distortions that make the playing field unlevel. So it is a model that seniors are already familiar with, the Social Security program, and it operationalizes a traditionally democratic idea. And as I mentioned before, I think that is really our only hope, well, our best hope for reducing the growth of Medicare spending and maybe even cutting Medicare spending over time. And it would improve the quality of care that enrollees receive as well.
One of the things that sort of motivates the principles behind Paragon's work, because government is going to subsidize a certain amount of health insurance and health care for lower income populations, for seniors, but that we should move to a structure where we fund the patient and not the system. And so much of the subsidies that flow through our healthcare sector are direct government payments to hospitals or health insurance companies. So, I mean, Paragon has developed options for how we can reform Obamacare subsidies, where those subsidies would flow to the individual, so the individual has choice over the type of coverage and care that works best for them. So I'm sympathetic to the reform that Michael is talking about at a principled level. It's obviously very hard to get there in the near term. I think given Medicare is the number one fiscal challenge, and there are a set of reforms that have been developed that would reduce the spending trajectory in the program, I will mention two. And I think they both address overpayments. The first is site-neutral payment reform. Medicare pays much more for services delivered in a hospital than identical services delivered in ambulatory surgical center, outpatient setting, physician offices. They really aren't justified. You've got agreement between policy experts at the Brookings Institution, at conservative organizations, that we should not have such a large differential and the Medicare program should be paying the same amount. The second is, and Michael mentioned it, Medicare Advantage. Half of seniors now are enrolled in Medicare Advantage. In Medicare Advantage, the government is sending health insurance companies a payment for each enrollee. And while we think there are a lot of advantages to Medicare Advantage and there's efficiencies with Medicare Advantage, there are changes that can be made to reduce. We think the level of subsidies to insurers is excessive. And we put out a paper last month on how we could reform Medicare through Medicare Advantage that would address what we think are over subsidies to health insurance companies and reduce spending in the program by $250 billion.
One of the challenges of trying to cut government spending on healthcare, however, is that there's so much lobbying by the healthcare industry. There's so much money they're spending. There's so many people from the district coming into their members of Congress's offices saying this will eliminate jobs, this will close the hospital, and so forth, that oftentimes the only way you can make a change to a program like Medicare is by increasing spending rather than reducing it. The example I like to use is A lot of people don't know this about Obamacare, but Obamacare reduced growth in Medicare spending by about $1 trillion over the first 10 years in which the law was in full effect. But the only way that they were able to get those reductions in the growth of Medicare spending into law was by promising the industry $2 trillion in new spending, which is the new spending under Obamacare's Medicaid expansion and under the subsidies for private health insurance through the Obamacare exchanges. And the Cato Institute has a book coming out called The War on Prices. I have a chapter in that book on healthcare prices, and I talk about the site of service differentials that Brian is talking about, where Medicare pays a hospital $2,000 to do cataract surgery, but it pays an ambulatory surgical center $1,000. And everyone says, wouldn't it be great if Medicare could pay both facilities just $1,000, eliminate that site of service differential? But when Medicare tries to do that, it is as likely, and I would argue more likely, to pay both entities $2,000 to eliminate the site of service differential by increasing the payments to the lower priced facility than to the higher priced facility, because both the hospitals and the ambulatory surgical centers will be in favor of that. But if you try to reduce the hospital's prices, the ambulatory surgical centers might favor it, but the hospitals are going to hate it and lobby against it. So cutting Medicare spending is an incredibly difficult thing to do because of all of that lobbying heft of the healthcare industry. And there's also not a lot of serious interest in reducing healthcare spending. And you can tell by the way people talk about the so-called Medicare trust fund. Brian rightly said that this is not a trust fund. There are no funds in it. It's a fiction. I would call it a lie, actually, that the government tells to the people that this is a trust fund that is helping to fund Medicare. What is actually happening with the so-called Medicare trust fund is that what we call a trust fund is actually a Medicare spending authority clock. And when the Medicare trustees say that the, quote, trust fund will run out of resources, what they actually mean is that Congress will run out of legal authority to spend money on Medicare Part A subsidies, so hospital subsidies. And when that happens, Congress is not going to be able to spend as much on hospital subsidies, and Medicare spending will automatically fall. Brian, you gave a figure for the benefit cut result, and I forgot what the percentage was, but it's a significant percentage.
Like 12%.
12% reduction in Medicare spending. You can tell that people aren't serious about cutting Medicare spending because everyone talks about that like that would be a horrible thing. That would be a tremendously positive thing. The best estimates suggest that 1/3 of Medicare spending do nothing to improve the health or increase Medicare enrollees' satisfaction with the health care they receive. And so a 12% cut would not necessarily leave seniors worse off. And we should be talking about cuts of that magnitude, but no one is focusing on how that would be a positive thing. No one focuses on how to use that as leverage to get better cuts or similar cuts elsewhere in the Medicare program. Instead, everyone talks about, and this is again a result of the influence of the health industry lobby, everyone talks about how that would be such a nightmare and we must avoid that at all costs. We must avoid, quote unquote, insolvency in Medicare, when really all we're talking about is the Medicare cuts that everyone says that they want, but then tries to avoid when the opportunity presents itself.
If I could jump in, I would say Congress did cut Medicare in the Inflation Reduction Act. I mean, some of those cuts went into higher Obamacare subsidies, but the vast majority went outside of healthcare and went to green energy subsidies. I think you're right about the ACA. There were significant Medicare cuts. The spending on new entitlements in the Medicaid expansion and the tax credits exceeded the level of the Medicare cuts. I do think we're at a different fiscal point now, though. The debt as a percentage of GDP is so high, and interest rates and inflation are higher than they have been in decades. I think we're going to have some type of fiscal reform package within the next 5 years. And I think Medicare reductions have to be part of it. Otherwise, the balance sheet and the projections of where interest rates are going to go are so dire that I do think now is an opportunity for us to be developing policy proposals that not only reduce Medicare spending, but also that address problems with the growth of Medicaid, ACA, maybe some issues around the employer-sponsored insurance exclusion. And I think one of the things that really motivates our work at Paragon is, like Milton Friedman said, When the crisis occurs, you don't know when the crisis is going to happen, but it's the ideas that are on the shelf that the politicians are going to select from. So we need to have well thought out, well vetted policy reforms. So when that opportunity comes, when there is going to be a moment for those of us that want to reduce the size of the federal government and reduce the amount of spending and subsidies that goes through federal health programs, there are politicians that are reasonably ideologically aligned that are concerned about debt, that don't just want to dramatically increase taxes, that have those proposals that are there to select from.